I think it's, yeah, he has done
Yes,
it.
ma'am.
Okay. Fine. So shall we start the program? Dr. Somasundram will starting the
Yeah,
program.
yeah, you can do.
Yeah.
Yeah.
Thank you. So a very warm welcome to all the delegates who have joined on the platform today. Again, yet another presidential action
கொஞ்சம்
plan.
வால்யூம் கம்மியா இருக்கு வாய்ஸ்.
Yeah, yet another presidential action plan to be started today, and I really thank all of you for joining on this platform. Before starting the program, I would request our treasurer, Dr. Rajkumar, to kindly deliver the pediatrician's prayer.
Thank you, Namada. Pediatrician prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, peace, and love to all children and their families, irrespective of status and creed. Give us the wisdom and understanding to change the things we can, retain the good, and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations, at all times, amidst all people. Thank you. Over to you, Narmada.
Thank you, Rajkumar sir. The PG teaching program has been the favorite of the presidents and has been carried on from the COVID time in a very successful way, and it has been very popular among the practitioners and postgraduates alike. But having taken it this year, Dr. Somasundram wanted to make it in a big way, and we have our coordinators Kritika and Prasanna doing a great work, and Dr. Somasundram with his visionary presidential action plan has made it mandatory that this takes a priority over the other programs. So Dr. Somasundram, over to you for your presidential address.
Yeah. So thank you, Dr. Narmada. So good evening, dignitaries on this platform. First of all, welcome Dr. Professor Singaravelu sir, our CIAP president-elect. So in spite of his OB meeting with the CIAP, he has joined us for a short brief period. Welcome you, sir. Welcome Professor Rajendran sir, who has done this postgraduate program in an extensive way, in a more meticulous pattern, along with Dr. Kritika, the associate professor from Teni Medical College. Welcome you, sir. Welcome our president-elect, Dr. Tirumurugan, who has been the technical the Dada for the IAP TNSC. So he has taken the technical aspect to greater heights. So welcome you, Dr. Tirumurugan. Dr. Manogar sir, he is the academic coordinator from the academy part. So he will be a guiding force for us with his vast experience. Welcome you, sir. And Dr. Rajkumar, Dr. Narmada, our secretary. So she's known for her vibrant activities. And you have seen her the way she does meticulously her work. And Rajkumar, very good friend, and he used. Pardon? So he is known for his account keeping, and welcome you, Dr. Raj, and Dr. M.S. Vishwanathan, our good friend of ours, who is the vice president during my tenure. He will be a greater help for me. So this team, the IAP TNSC team, with the core team of the the postgraduate teaching. So every time the postgraduate teaching, the name changes. But you know that the last year during my tenure, during the CCB president, I had the terminology something different because it will attract the PG, something called as the virtual Gurukulam. So the same terminology is being carried over to this time also in the terminology as virtual Gurukulam. You know that Dr. S. Balasubramaniam sir, so he was there for all the 11 programs we conducted during my tenure as Chennai City Branch President. So here also, sir has accepted to be here for all the year-long postgraduate teaching, sir. Thank you very much, SBS sir, for being here and guiding us as the scientific advisor for the postgraduate program Virtual Gurukulam. The two other conveners and the coordinators, Dr. Kritika, who was coordinating or convening the last year postgraduate, is being retained as the convener. Welcome, Kritika. Your vast experience will definitely be a guiding force for the postgraduates, and that will be benefited. The postgraduates will definitely be benefited. Dr. Prasanna Raju, the professor of pediatrics from SR Medical College, he was doing the rituals for the Virtual Gurukulam of Chennai City Branch along with Dr. Nisha. So he will be continuing as the coordinator for this program. So the three, Dr. SBS sir, Dr. Kritika and the Dr. Prasanna as a team who are or already has the experience of taking over the virtual Gurukulam for an year will be the force. Coming to the faculties, so I wanted a minor change because see what I felt was the case presentation immediately starts and you know that the PGs will take another 5 to 10 minutes to log in. So in that 5 to 10 minutes or 15 minutes, let us have a topic of interest which is important for PGs, but it was not detailedly described or discussed in most of the case presentations. So the first 15 minutes will be a topic of interest which is important for the PGs that will be discussed by a different faculty. So in this first session, Dr. Hemchand will be discussing the growth charts. So likewise, it will be various topics of interest for the first 15 minutes of the session will be discussed by various faculties. Then comes the case proper. So we start with the neurology case discussion, and thank you, Dr. Janani Madam and Dr. Aisha, for meticulously preparing the postgraduate in a short span of time from Child Trust Hospital. Thank you very much, Madam. For this, we have Dr. Sangeeta, my batchmate, my unit mate in ICH between 2003 to 2006. She has grown to greater heights and she is the professor of pediatric neurology, DM from AIMS, pediatric neurology from AIMS. And welcome, Sangeeta. So we will
We
be very
request you
glad to
to
hear
mute
you.
yourself, Dr. Kumar, Dr. Benny Benjamin. We request you
And
to mute.
Dr. Vishnu Bhatt sir, sir is the retired dean and professor of pediatrics from JIPMER. Now she is currently the advisor of AVMC. Welcome you, sir. Your expertise will definitely be a guiding force for the postgraduate teaching. So with this, I hope this teaching program will be benefiting both the postgraduates, the postgraduate teachers, and the practicing pediatricians. And wish you all a happy learning. Thank you very much.
Thank you so much, Dr. Somasundram. Indeed, it's a very novel thing to call it as a virtual curriculum, and this really creates the Guru Shishya Parampara, and we have also included in our flyer also the same way. Brings a lot of discipline and commitment to this program, and we are very happy to have it on board. Dr. Singaravelu sir, who has been a great doyen of support for us for all our programs last year and this year also. Sir, we really thank you for joining us in spite of the OB meeting, which is very important for you. But we are very happy that we are here. You are here, and when you are here, it's always a great. People are also very happy to see you on the platform. Dr. Singaravelu sir, over to you for your short felicitation.
Thank you, Dr. Narmada. Respected President Somasundaram and immediate past President Dr. Rajendran, President-elect Tirumurugan, Vice President our MSV, and Secretary Narmada, Treasurer Rajkumar, and all my great teachers, Vishnu Bhatt sir, Srinivasan sir, SBS, Jani ma'am, and all. And it's a proud moment that I'm with our team that inaugurating this third program of this year of Presidential Action Plan, where Kritika is here as a coordinator, and definitely I know that whatever Somasundaram plans in such a way that almost it is going very well. All the program with attended by very many people. So definitely, and he didn't want to waste time. Before starting that, also giving a short lecture for benefit of today Guru Chat is going to be done by our Hemchand. It will be really useful to all the postgraduates, not only postgraduates, even for practitioners. I do not take much time. So I thank every one of you, and especially the present team, for giving me this opportunity for inaugurating all the program. I'm really lucky, thankful that definitely this year will be going a very good academic and all aspects because of rich experience of Dr. Somasundaram and his team will definitely do. And our IAP TNSC is going at very higher level, at par more than with our central IAP. I am very proud to be with you all. Thank you. Wish you all the best. Happy learning. Thank you, sir. Thank you to all, sir.
Thank you very much, sir.
Thank you so much, Dr. Sangaravelu sir. It's been a pleasure having you here. And having been the secretary for IAP TNSC for 2 years, it's always a great privilege to learn under two presidents. And I've been really grateful to work under Dr. Rajendran sir, who taught me to be very meticulous in not only the planning and also in execution. And he was a master executor, and we all know the commitment and the work he had shown for the previous year. We are very happy that you have joined us here, Dr. Rajendran sir. Over to you for your felicitations.
Thank you, Dr. Narmada. And most respected our President-elect, Dr. Singarwal sir. And in spite of his busy schedule, sir has joined. And most dynamic President, Dr. Somasundaram, and young and energetic and President-elect, Dr. Thirumurugan, and Secretary, Dr. Narmada, and Treasurer, Dr. Rajkumar, and Vice President, Dr. MS Viswanathan. And all stalwarts are here, Dr. SP sir, and Dr. Srinivasan sir, and Dr. Bhatt sir, and my good friend, Dr. Sangeeta also here, and Hemchand also here. On behalf of IAP TNSC, I welcome each and every one of you. I am really happy that this PG teaching was started on 2019 when I was treasurer because of COVID time. We have started this program. It is almost 7th year, and it's evolved into the virtual curriculum, and as well as a lot of rejuvenated program also. And each and every year it is going a different mode, and as well as growth also. And really appreciate Dr. Somasundaram to continue this PG teaching with the virtual curriculum. And I really appreciate that Kritika is one of the very dynamic person, as well as very sincere person, and is program convener, as well as advisor, Dr. SPS sir, and as well as program coordinator, Prasanna Raju. My best wishes, and hope this program will go further, and it will enrich our PGs also. And once again, thank each and every one of you. Thank you very much.
Thank you so much,
Thank
Dr.
you.
Rajendran sir. Now I call upon Dr. Thirumurugan Saren, our President-elect 2026, who has been one.
Your voice is very low.
Now I call upon Dr. Thirumurugan Saren, our President-elect 2026, who has been a pillar of support in organizing the conferences, and we all know how a dedicated workaholic he is. Over to you, sir, for your felicitations and wishes for the program.
Thank you, Dr. Narmada.
The video is switched off.
No, because I'm just, I think there is a network issue. That's why I can't now. That's okay. Good evening, everyone. My close friend, Dr. Somasundaram, President IAP TNSC, President-elect Dr. of IAP, Dr. Singarwal sir, immediate President 2025, Dr. Rajendran, Dr. Narmada, Secretary, and Dr. Vice President, Dr. MS Viswanathan, and Treasurer, Dr. Rajkumar. I'm really happy that our postgraduate planning team, clinics is continuing in various names. For the number, those who are interested in numbers, today is the 125th episode. So it started way back in, as Dr. Rajendran sir said, way back in 2019, 2020. And then today is the 125th episode, and I'm really happy that each and every subsequent presidents have vowed to continue it, though in different names. But the objective has always been the same, which is to improve and enrich the knowledge of our postgraduates. And this is probably one of the long-running programs of the IAP, not only Tamil Nadu, but even all over the country. So I'm really happy that in its new avatar, it's going to be very useful and for the postgraduates. And so I'm really thankful for Dr. Somasundaram coming up with this idea of having a 15-minute session on an important topic. So thank you very much, and my best wishes and happy learning. Thank you.
Thank you, Dr.
Yes, sir.
Thirumurugan. I'm very sure this is one of the wonderful programs that will be continued, and it is always a pleasure to learn from great teachers. Now I call upon our Vice President MS Viswanathan sir for a very short felicitation.
Good evening, and thank you, and greetings to President, Vice President, past President, President-elect, and the Secretary and Treasurer. And of course, the important thing is the virtual, the academic convener, Dr. Manohar, and the virtual curriculum team, Professor SBS, Kritika, and Prasanna. And of course, the mentors for this today, Dr. Janani and Dr. Aisha, and the teachers, the gurus, are very important, Professor Vishnu Bhatt sir and Dr. Sangeeta, and all the teachers who have joined also. I think it's not only the opportunity for the PGs to learn, it's also opportunity for the teachers to fine-tune their teaching ability so that they exactly teach what is needed for the candidates, for the students. And it's very nicely enough to aptly, we are starting with a very basic topic as growth charts, the basic of pediatrics. Thank you very much.
Thank you so much, Dr. MS Vishwanathan. I request kindly Dr. Balashankar. Dr. Bala sir, please kindly mute yourself.
Now
Kritika,
the
you
pace
can
ran.
mute.
Now the pace ran. Narmada, I will talk to
You are
you.
the host now. Can you mute
Host
Dr.
Kritika, can you
Balashankar?
mute Dr. Balashankar?
Yeah.
Thank you so much, Vishwanathan sir. Now I request our academic coordinator, Dr. T.N. Manohar sir, whose experience and the meticulousness has taken every program of ours to a great height. I am very happy that you have joined our team as academy coordinator. Over to you, Manohar sir, for a short felicitation.
Thank you, Dr. Narmada, for the nice introduction. Good evening, all. My warm greetings to Dr. Singaravelu, the Central IAP President-elect, Dr. Rajendran, former President of IAP TNSC, Dr. Somasundaram, Dr. Tirumurugan, Dr. MS Viswanathan, Dr. Narmada, and Rajkumar, and all the doyens and delegates and PGs who have joined on this platform. Dr. Somasundaram is continuing the legacy of his predecessor, Dr. K. Rajendran, with his vision and wisdom. Today, we are starting with his third presidential action plan. In ancient times, students were going to the hermitages, to the teachers, residents, and learning. Then came where the teachers and students assembled in an institution and they had the teaching, they were learning. Now, we have, with the vision of Dr. Somasundaram, the term virtual Gurukulam, where the student and the teachers are sitting at their home and they are teaching and we are learning. Today, it will be dealt in two parts. The first part will be on pediatric pearls. After Nachun and all point, we have now probably will have Mechin and Napadu point from this pediatric pearls. Dr. Hemchand Prasad, renowned pediatric endocrinologist, who makes any topic look simple by a step-by-step approach, will be delivering this. The second part is case discussion. Under this, neurology case will be discussed. This will help not only PGs but also practitioners to relearn the concepts beyond textbooks. To share their wisdom and knowledge, we have the following gurus: the legendary pediatrician and neurologist Dr. Vishnu Bhatt, who was former director and dean of Jipmer Pondi, now working as advisor for research and publication at Arupadai Vedu Medical College. Dr. Sangeeta, another faculty from renowned institute CMC Vellore. She is a neurologist with special interest in epilepsy, neurometabolic disorders, neuroinfections, neuroinflammatory disorders. And we have Dr. Aisha Mariam, pediatric neurologist from KKCTH, the institute which has produced many gold medal winning DNB students. Dr. Aisha Mariam, specializes in management of epilepsy, developmental delays, ADHD, and sleep disorders in children. She is the mentor for the case presenter, Dr. Kritika, who is exuding so much of confidence. Let us hear from them and become wiser. Thank you.
Thank you so much, Manohar sir, for a very nice introduction of the program as well as the speakers today. And thank you so much. I still remember the days when I was a postgraduate. We used to be in ICH, but we used to run for the classes at 6:30, which was taken by Balasubramaniam sir at KKCTH. So that was the a kind of interest he had shown to train for all the DNB students, and we were all waiting for his classes. It was so important to get his points, and it was, all of us know, it was a cakewalk for us during the DNB exam. So I'm very happy that he's still mentoring so many students in his career, and he continues to guide us in this novel platform. Nowadays we don't need to run at 6:30 in the morning, though it was an experience by itself, and he taught us meticulousness. But I'm very happy that he is going to be the person who's going to guide the program, and I request all the postgraduates to make the best use of such great teachers who are ready to take their time and wisdom and to join us, rather than, they can do any other thing, but they have taken their time and been with us. Balasubramaniam sir, thank you so much for continuing yet one more year of your teaching in the virtual platform. Over to you for a short felicitation, and then we'll go ahead and I'll hand over the mic to Kritika.
Thank you, Dr. Narmada. All I have to say is to welcome all the students, all the senior faculty, and all the office bearers and VIPs of IAP. Let us all learn together, and I'm sure PGs would benefit a lot with experienced people. I see Aisha was our own student of KKCTH. She's going to be part of it. So many seniors are taking part. I'm sure the PGs will not get a better opportunity to learn clinical pediatrics. All the best. Thank you very much.
Thank you so much, Balasubramaniam sir. Kritika and Prasanna, you are the young beacon of hope and very dynamic people who have really held the fort for the last year, one in Chennai CC branch and the other to the state. But you have combined together. We are going to have a dynamic duo doing the work. I'm very sure further on, all the programs will be a master blaster. So you started off with a master blaster, Dr. Hemchand here, and we are very happy from IAP Tamil Nadu State Chapter that you have accepted and help us in the coordination. Your meticulous planning has made us the flyers to reach in a very big platform. Thank you so much for all your help, and over to you for taking over the program. And I'm very happy that Dr. Hemchand, very close friend, and in fact he helps me even when I call from Vellore in guiding us, and I'm very sure he'll be a great mentor to the postgraduates also, that he is delivering the first lecture. Kritika and Prasanna, over to you for further proceedings.
Prasanna sir, after you.
Thank you, madam. I think we are lack of time. I thank all the.
Don't worry, this is because it's the inaugural function of the third presidential action plan. It will be like that from next week onwards. The platform will be given to Kritika within 2 minutes of starting the program. Kritika and you.
I just want to thank all the faculties and Janani madam and PG students who have accepted in a very short notice. And I thank Somasundaram sir and Dr. Narmada madam and Dr. Balasubramaniam sir for coming. And I thank all the senior IAP TNSC members and stalwarts here. Over to you, Dr. Kritika.
Respected Professor Singaravelu sir, respected Somasundaram sir, Rajendran sir, Thiru sir, dear Narmada ma'am, Rajkumar sir, MSV sir, Srinivasan sir, and the academic coordinator Dr. Manohar sir, scientific advisor, the legendary Dr. SBS sir, Prasanna sir, good evening, and thank you so much for trusting me and having given the opportunity to me. And respected Namaskarams to Gurujis, Dr. Vishnubhat sir, Dr. Sangeeta ma'am, and Dr. Aisha ma'am, Dr. Janani ma'am, and greetings to dear Kritika. It gives me immense pleasure to be a part of this virtual Gurukulam 2.0, along with the scientific advisor, Professor Dr. SBS sir, Prasanna sir, and Manohar sir. As Manohar sir told, these two portions are there. And learning is something like we have to catch up with the evolving innovations at the same time without compromising the basic clinical excellence. So this program addresses both. So for first portion, that is what is new in pediatrics. No one can deny that growth chart is the most useful tool in pediatrics. And who else can tell us the new updates other than Dr. Hemchand, who is a consultant pediatric endocrinologist in Mehta Multispeciality Hospitals. Welcome and greetings, dear Dr. Hemchand. Over to you. Can you please share your screen? Hemchand?
Yeah.
Hi, good evening. Thank you for
able
accepting.
To share it?
Yes, ma'am.
Thank you.
I hope I'm visible and audible.
Yes.
Yeah,
Very well.
okay.
Very well.
Yes, thank you. Thank you very much, IAP TNSC, for this nice opportunity. So I'm beginning this with setting my timer on. So over the next 15 minutes, we will look at some 10 interesting pearls on what is new as far as growth chart is concerned. The work of the Indian Academy of Pediatrics uh, to optimize the growth of Indian children through evidence-based tools is phenomenal to make it more and more user-friendly. And I think it's really like hunting for a pearl. So over the next 15 minutes, I'm going to present 10 pearls which will help us to distinguish between normal children and children with a growth disorder. I think way back, Indian Academy of Pediatrics came up with the very useful growth monitoring guidelines in 2007, where they recommended specific anthropometric measures to be measured at specific age groups at periodic intervals to identify normal and diseased children, which included length, weight, and head circumference at every vaccination visit in the initial 2 years of life, every 6 monthly measurement of height, weight, and head circumference at in between 2 to 5 years, and above the age of 5 years, annual measurement of height, weight, BMI, and sexual maturity rating. I think this stands true even after 20 years. And having known what to measure, I think when to measure and how to plot, we have to use the Indian Academy of Pediatrics simplified WHO charts for children below 5 years, which allows a single page measurement of length, weight, and head circumference on the front side and the weight for height on the back side. For children above 5 years, the Indian Academy of Pediatrics recommends the use of pediatrician friendly growth charts, which are indeed very friendly with all the pediatricians to identify children who do not have and who have growth abnormalities. Once you make the measurement, plot it on the right growth chart, interpret it properly. Whenever you have height below the third percentile, make a diagnosis of short stature. Whenever you have weight below the third percentile, below 5 years, you consider it as underweight. Above 5 years, you do not use the terminology. When you have the weight for height or BMI below the third percentile, you tend to call it wasting or underweight and wasting. And children above the 97th percentile are considered overweight below 5 years, and above the 23rd adult equivalent are considered overweight above the age of 5 years. Rapid crossing of percentile lines in a 6 month period during infancy and a 1 year period during childhood is considered abnormal. So I think the first pearl we should remember is please follow the IAP recommended growth monitoring guidelines. Use the IAP recommended WHO charts and the pediatrician friendly IAP charts and identify growth abnormalities as per the standard definitions of the WHO and the Indian Academy of Pediatrics. That is pearl number one. With the rapid rising pandemic of obesity, what is the second pearl which the Indian Academy of Pediatrics has provided us is the BMI lookup tool. These are very simple BMI lookup tools which helps us identify overweight, obesity, and underweight in children above the age of 8 years. All you need to do is to measure the height, measure the weight, and plot it. And where the position of the plotting lands, you classify it as overweight if it is above the yellow line, obesity if it is positioned above the red line, and underweight if it is positioned below the black line. Very simple. I think the word pediatrician friendly is indeed valid because you obviate the need for a calculation of BMI using a calculator. A simple plot helps you identify children with overnutrition and undernutrition. It is useful for children above 8 years. It is gender specific. It obviates the need for BMI calculation, but it needs to be validated on a larger population. Varied sensitivity and specificity has been reported. In extremes of height, please be careful, but it remains a very, very, very useful screening tool. The second pearl the Indian Academy of Pediatrics has provided us is the BMI lookup tool. The BMI lookup tool, the advantages, no need to calculate BMI. It helps and it also helps us to identify the onset of metabolic complication. Be very careful in very tall, very short people, and remember it's not validated in large data sets. You're a busy pediatrician. There is a constraint of time to calculate the mid-parental height. Again, the third pearl the Indian Academy has provided is the mid-parental height percentile calculator, which is very useful in a busy office setting. All you need to do is to measure the parent's height, the father's height, the mother's height, and you kind of connect the two in the mid-parental height percentile calculator as it has been done in this particular slide. And you can see the percentile of the mid-parental height is arrived at without any manual calculation of the mid-parental height. In this child, if you see, the child's height is at the 10th percentile, the target height is also at the 10th percentile, indicating that the child's current height and the genetic potential of the parents is matched. So without having the need to use a calculator, you are arriving at a mid-parental height calculator. This is the third pearl which the Indian Academy of Pediatrics has provided. It is based on the concept of regression to the mean. Children who have very deviant heights in terms of parents who are very tall, very short, the validity needs to be ascertained. But remember, any difference in 2 percentiles between the target height and the child's height should be an alerting point for the pediatrician. I repeat, any difference in 2 major percentile lines between the target height percentile and the individual child's height percentile should be an alerting point for the pediatrician. This has not been validated, but remains the most useful pearl, the third useful pearl to ascertain, to understand the child's height in the perspective of the parent's height. My child's growth seems to be slow. The cousin is raising her in growth. Is my child's growth okay? Again, the fourth pearl which the Indian Academy of Pediatrics has provided is the Indian growth velocity charts. The Indian growth velocity charts helps you to distinguish between a goods train, a Rajdhani Express, a Bullet Express, and a static train. All you need to do is to take the Indian growth velocity charts, calculate the change height velocity based on the change in height in between 2 points. The height velocity is extrapolated to 1 year, and the height velocity is plotted in between the 2 time points, the midpoint between the 2 time intervals. And if you find the child's height velocity below the 25th percentile, it is a red flag sign. Be careful. And if you find the growth velocity above the 75th percentile, look into this child more carefully for any causes of rapid overgrowth. The Indian growth velocity chart remains the fourth important pearl the Indian Academy of Pediatrics has provided to identify children who may or may not have a growth abnormality. My baby is a preterm IUGR baby, looks very small. Does she need help? Again, the Indian Academy of Pediatrics has come up with a very useful extended growth chart for the use in children who are born small for gestational age. A very useful tool in this special subset of children where a careful path has to be treaded to not overdiagnose and overintervene, as well as underdiagnose and miss the opportunity to intervention. The extended growth charts have 3 additional percentile lines below the 3rd percentile, corresponding to the minus 2.25, minus 2.5, and minus 3 Z-score lines. And all you need to do is to measure the growth and plot it on the extended growth chart. And the alerting point for the neonatologist is to see whether the child's growth is below the minus 2.5 Z-score line or above the minus 2.5 Z-score line. So if you find the child's height below the minus 2.5 Z-score line, SD line, you have to look into this child more carefully. Whenever the height is below the minus 2.5 Z-score line, look into this child more carefully, and you might have to optimize the growth by intervention, especially if the child is above the age of 4 years. A careful, meticulous assessment and the close look into the growth of the child should be made into. So this is the next important pearl which the Indian Academy of Pediatrics and Indian researchers have provided us, the extended growth charts for use in babies who are born SGA and who are being followed up in the long-term follow-up clinics. My baby was noted to have small limbs in the antenatal scans. Is my child okay? The child looks small in compared to his peers. Again, this is a common scenario which is encountered by the Indian pediatricians. Are the bones okay? Is there some skeletal disorder? Again, there are Indian proportion charts which are available, where the Indian proportion charts are developed based on around 5,500 children from one part of the country, and percentiles have been computed to develop very useful charts which help us identify the perspective of the upper segment and lower segment for boys and for girls, and the position of the upper segment lower segment ratio helps us identify short limb dwarfism or probable short trunk dwarfism, which help us rationalize further plan of management, including a skeletal survey, a genetic testing, etc. And remember, skeletal disorders are one important arena where there is an explosion of diagnostic and therapeutic modalities, and a lot of children are being given appropriate treatments, and they are again able to attain a good improvement in their long-term stature. So the next important sixth pearl, which is recommended and advised and available for Indian pediatricians, is the upper segment, lower segment charts in children with specific short stature and possible skeletal disorder to help us look into the possibility of a short limb or a short trunk dwarfism. Here is a next scenario which a pediatrician is going to encounter: severe obesity, weight of 150 kilos, BMI of 40, BMI of 50, and definitely a lot of us are encountering such children, and this is not going to just respond to lifestyle. When do we consider intervention? Again, the Indian Academy of Pediatrics has done immense work and come up with the extended BMI charts to identify class 2 and class 3 obesity based on the whether the BMI is 120% above the obesity cutoff, it is labeled as class 2, and 140% above the 27th or the BMI cutoff of obesity is labeled as class 3. You can consider pharmacotherapy in children who are aged above 12 years with class 3 or class 2 with significant comorbidities. These are the extended BMI charts, again available in the Indian Pediatrics, to identify children who have class 2 or class 3 in extremes of obesity. And whenever you find the child has class 3 obesity or class 2 obesity with significant comorbidities, you might have to put these children on appropriate intervention beyond just lifestyle measures. This is the important seventh pearl which the Indian Academy of Pediatrics has provided to practitioners to identify and stratify children with obesity to decide the aggression of the action that is required. Rapidly increasing tummy, should I worry? Another important concern raised by a lot of parents, a lot of health conscious parents, about the long-term health of their child. The eighth pearl with the Indian Academy of Pediatrics is the Indian waist circumference charts. The Indian waist circumference charts are available based on a data of about 10,000 children, where the waist is measured at the end of expiration just above the right ilium. It helps to identify cardiometabolic risk and metabolic syndrome. Waist circumference above the 70th percentile is considered metabolic risk as per the current Indian Academy of Pediatrics guidelines. So these are the waist circumference charts for Indian children, and you can see the red line which corresponds to the 70th percentile. And when your waist circumference is above the 70th percentile, you identify this child to be at a significant cardiometabolic risk factor and be more aggressive in the lifestyle interventions that you do. Too much of records in the hospital, no space. Parents do not maintain records. They do not carry their records, growth records for their visits. What next? Again, Indian Academy of Pediatrics has again worked towards easing the work of pediatrician by developing the Indian Academy of Pediatrics growth chart application, which is available both on App Store and Play Store. And all you need to do is look at the child, choose the sex of the child, choose the age of the child, enter the anthropometric parameters that you are measuring, and look at the beautiful presentation of the height, weight, head circumference, BMI, and weight for height, both in terms of percentiles and the position on the growth chart to identify and satisfy the parents, and also presenting the Z-scores to identify how deviant the child is, how significantly deviant, and whether the deviation is on the positive side or on the negative side. Here you can see the weight Z-score is minus 5.2. So the child is 5.2 standard deviations away from the aggressive action would be required for this child. IAP application complements growth chart use. It is free for download. It can be retrieved when it is linked with the mobile number. It helps children, it helps us to go green and have a more environment friendly approach. And the last and the most important pearl is, look at the array of charts, and what is really strikingly common amongst all of these is they are almost every chart is color coded. There is a red line, there is a possible yellow line to alert you and involve the parent as a partner to facilitate and reassure them, or alert them and explain to them the need for a possible assessment and intervention or some lifestyle related action, both for boys child, girls chart as well as boys chart. You can see that the charts are so beautifully color coded to satisfy and alert the parents. Never fail to explain the 10th and the last and the most useful part. Just partner them and involve them in the care of the child. To summarize, pearl number 1, follow the Indian Academy of Pediatrics growth monitoring guidelines. Use the IAP modified WHO charts in children below 5 years, pediatrician friendly charts in children above 5 years, identify growth abnormality. Pearl number 2, BMI lookup tool complements BMI assessment of growth charts in office practice without having the need of a calculator. The MPH percentile calculator complements the target height calculation and helps you arrive at the target height percentile and helps you understand the child's height in the perspective of the target height, really making the Indian growth chart plotting calculation free and indeed, I quote unquote, user friendly. The 4th pearl, use the IAP or the Indian recommended growth velocity charts and alert yourself when the growth velocity is below the 25th percentile. Pearl number 5, use the extended growth chart, especially in SGA babies, and identify those who do not catch up below minus 2.5 STs above the age of 5 years. Pearl number 6, use the Indian proportion charts to identify those with deviant upper segment, lower segment ratio above or below plus and minus 2 standard deviations. Pearl number 7, use the extended BMI chart to stratify extremely obese children as class 2 or class 3 and plan appropriate intervention. Pearl number 8, use the waist circumference chart to identify metabolic risk, especially if the waist circumference is above the 70th percentile. Pearl number 9, use the growth chart application. It complements assessment of growth charts and it helps you to go be environment friendly and maintain records linked to the mobile number. And pearl number 10, and the most important pearl, always remember charts are color coded. Explain what the chart tells you to the parent and either reassure them or alert the parent. Using these 10 pearls, I think one would be able to identify and distinguish between children who have normal growth and abnormal growth with a reasonable good efficacy and accuracy. Thank you very much for your patient hearing, and I'm happy to have ended exactly at 15 minutes. Thank you so much.
Thank you so much, Hemchand, for that clear and crisp lecture and for gifting us that beautiful garland made of 10 shining pearls. Any questions or remarks or doubts? If there are no questions, then let us move on to the section 2 of today's program. As postgraduates, we all had many sleepless nights working at the bedside of the patients, just hearing the beeps of the monitors. They never scared us, but what scared us the most, it is that final university practical exams. We all would have felt like Abhimanyu got strangled inside that Chakravyuha, being thrown so many questions as astras by the examiners. But who can guide us out of it? So we have our gurus to show us the way to get through that Chakravyuha gracefully and successfully. So today we have with us two eminent gurus, Professor Dr. Vishnubhat sir and Dr. Sangeeta ma'am for guiding us. And we have the presenter, Dr. Kritika, who will be presenting the case on a floppy infant. It will be like a model university exams. Kritika, can you please share the slides? Under the able mentorship of Dr. Aisha ma'am. Can you share them now? Yeah. Vishnubhat sir, Sangeeta ma'am. Sir, your opening remarks, please, sir.
I can see.
Yes, sir. Shall I ask her to proceed, sir?
Yeah. I think let her present and then we'll ask whatever we want to ask.
Yes, sir. Yes, ma'am.
A very good evening to one and all present here in the forum. I'm going to present a case on floppy infant. This is a 12-month-old female infant hailing from Chennai, whose informant is mother and her reliability is good, brought with the chief complaint of floppiness of all 4 limbs since 2 months of age and delay in attaining motor milestones since birth when compared with the elder sibling. and she had poor weight gain since birth, currently admitted with the concerns of fever with crying during micturition for the past 3 days. The presenting illness begins from the newborn period. So I would like to present from antenatal history, sir. Maternal age at conception was 26 years, and it was a non-consanguineous marriage, spontaneous conception. This pregnancy was confirmed by urine pregnancy test at 45 days of amenorrhea. She is registered and immunized at primary health center. Periconceptional folic acid was not taken. There was no history of drug or irradiation exposure during the first trimester. No fever with rash. A dating scan done and given the dates. In second trimester, quickening felt at 20 weeks of gestation. Fetal movements were perceived normally, like in first pregnancy. No history of gestational diabetes mellitus, hypertension, or hypothyroid. No history of drug exposure other than iron folic acid tablets. No history of oligohydramnios or polyhydramnios documented in the second trimester. Anomaly scan was done in PHC and told to be normal. 2 doses of tetanus immunization was given. In third trimester, she had a history of oligohydramnios for which she was admitted and given IV fluids. Growth scan done in third trimester was normal. Coming to birth history, it is a term baby, 38 week, delivered by lower segment cesarean section in view of previous lower segment cesarean section and breech presentation. Birth weight was 2.1 kg and the baby cried at birth. No history of NICU admission and the baby roomed in with mother on the day of birth. No birth asphyxia, no neonatal seizures or neonatal hypoglycemia or neonatal jaundice. On day 1 of life, there was no contractures or no fixed joint noted. Coming to history of presenting illness, a mother noticed child was floppy since 2 months of age. From birth till 2 months, there was mild floppiness, but spontaneous movement were present. From 2 months of age onwards, she had an evident feeling of slipping through the hands when held under the shoulders. And she had delayed motor milestone when compared with the elder sibling. She had attained head control at 4.5 months and complete rollover attained by 9 months. Currently, the child is able to sit without support. And the child is able to lift the arm above the shoulder, able to reach out and hold the objects and transfer object from one hand to other and even grasp small objects, able to lift the head off from the bed, able to turn in the bed but not able to sit from supine position. And she had feeding difficulties in the form of poor sucking, not able to suck from the breast since day 1 of life. So she was given expressed breast milk via Paladite till 40 days of life. Then the baby demanded more. So they gradually switched over to direct breastfeeding along with expressed breast milk. And there was issues with swallowing semi-solids when transitioned to complementary feeding. Duration of each semi-solid feeds took approximately 1 hour for even small quantities compared to liquids. She is not able to take solids now. No, there was no history of nasal regurgitation of feeds or choking or vomiting or drooling of saliva. She also had slow weight gain since birth till 6 months of age and not gained weight when she was started on semi-solids. Until 6 months, she was gaining weight slowly. At birth, she was 2.1 kg. There was doubling of weight at 4 months of age, and at 6 months, she weighed around 5 kgs. Since then, she is in 5 to 5.5 kg till 10 months of age. Hence, she was started on NG tube feeds with formula and complementary feeds since 10 months of age. After tube feeds, she has gained weight. Current weight is 6.9 kgs. And she had a history of recurrent respiratory infections. At 45 days of life, she had bronchiolitis, treated as outpatient with nebulizations, followed by she had nebulized twice. And at ninth month, she was admitted for lower respiratory infection for 3 days, and at 10th month, admitted for 2 days. And at 11th month, she was admitted for culture positive urinary tract infection, evaluated and told to have reflux into the kidney. Currently, she presented with history of high-grade fever for 3 days. Not associated with rigors, history of crying while micturition, reduced activity and decreased urine output noted for 1 day. There was no history of upper respiratory and gastrointestinal symptoms during current admission. She is treated as urinary tract infection. And she is alert, higher mental function histories. She is alert, recognizes mother's face and will play with the elder sibling. No history of squint, ptosis or visual disturbances. No history of deviation of angle of mouth while eating. No history of drooling of saliva, nasal regurgitation of feeds. No history of involuntary movements. History of crying while receiving injections and vaccinations. No history of continuous dribbling of urine or constipation, and no history of spine and joint deformities. No history of abnormal breathing pattern, stridor or rattling. No history of easy bruising of skin. No history of excessive sweating or flushing of skin. No history of contractures. No history of encephalopathy following febrile illness, and no recurrent vomiting. No history of seizures or diurnal variation of weakness. Shall I continue, sir?
Yeah, in the history, did you have any, you said excessive sweating. Did the child have any decreased sweating or decreased lacrimation?
No, ma'am. No decreased sweating.
Any fractures in the past?
No, ma'am. No history of any fractures. No decreased sweating history, ma'am.
So because of the feeding difficulty, she had recurrent aspiration leading on to recurrent hospitalization for respiratory infection, or it was like recurrent wheeze requiring hospitalization?
It was like recurrent wheeze. Every time she had lower respiratory findings, ma'am, wheeze, crepes, no aspiration history as such, ma'am.
Okay, and is there any diurnal variation of the weakness? Is there any fatigability while playing with the sibling? Like, did the parents observe any diurnal fluctuation of weakness?
No, ma'am. No diurnal fluctuation of weakness.
Pre-intercurrent illness, was there any worsening of fixed weakness? Like there is fluctuation of weakness where like the child becomes more floppy during the intercurrent illness, and if there is any change in the color of urine and any muscle pain, excessive irritability?
No, ma'am. Intercurrent, when the illness is settled and they are going home, means the child is doing well for the 20 days, ma'am.
Okay.
That's it.
I think you presented quite well. This mother noted from the beginning that there is some problem. Did she take any treatment or she left it like that?
No, sir. The mother, during vaccination, she is taking vaccination from primary health center, sir, with the IAP schedule from private schedule. During that time, she consulted a pediatrician. There, they told to close follow-up for developmental issues, sir. For feeding issues, till 6 months, she was gaining weight slowly, so they were not concerned about that, sir.
No, gaining weight slowly is fine. She's not gaining adequate weight.
Yes,
so
sir.
When they go for immunization or consultation, somebody must have told her there is some problem. So,
yes, sir.
What I'm trying to say is that whether any treatment was given.
No,
sir,
not given.
Respiratory tract infection. Could it be related to the aspiration because she's not able to swallow properly?
Yes, sir.
So these things also are important.
Yes, sir.
And you said weight became doubling, tripling like that. So do you think it is horse good baby who is low birth weight? See, normally you say, when does the birth weight double?
5 months of age, sir.
So by that criteria, probably the weight was all right, you mean to say.
Yes.
But this holds good only for a normal weight baby.
Yes, sir.
Suppose the baby is preterm or low birth weight, this doubling, tripling will occur much earlier.
Yes, sir.
So it should have been recognized that child is not growing.
Yes,
and
sir.
also not attaining milestones appropriately. So should have taken treatment much earlier than that.
Yes, sir.
So there are two things we have to differentiate. One is progressively whether the child improves or child deteriorates. Here from the beginning, the child has a problem.
Yes, sir.
So it is gradually improving, but not up to the mark.
Yes, sir. Gradually.
Why it is important to know whether the child is improving or deteriorating. See, some babies will attain milestones, then
Yes,
they
sir.
will start losing milestones.
Yes, sir.
Whereas this baby from the beginning has problem, but is not gaining as per its age. So what is the difference?
After achieving all milestones, if there is a loss of attained milestones, means neuro regression, we should rule out, sir.
Yes. So this is obviously not a neuro regression, but it is not
Yes, sir.
growing. Okay. Can continue.
Yes, sir.
Sangeeta ma'am, your questions, ma'am.
Yeah, is there any seizures or any other signs of upper motor neuron involvement?
No, ma'am. No seizures, ma'am.
No other involuntary movements?
No, ma'am. No fasciculations, no seizures.
Okay, you can proceed with the developmental history.
Yes, ma'am. In development, gross motor milestone, head control attained at 4 to 5 months, rollover from belly to back at 6 months and back to belly by 8 to 9 months. She was able to sit in tripod fashion by 9 to 10 months. She's currently sitting without support and she's trying to crawl on the abdomen. And her gross motor developmental age is 8 to 9 months. Developmental quotient is 66%. And fine motor, she tried reaching for objects at 6 months of age, palm or grasp attained at 7 months, transfer of objects by 8 months, and mature pincer grasp by 12 months. It is appropriate for age, sir. Fine motor developmental age. And in language, she had cooing at 3 months. She started speaking in monosyllables by 7 months and bisyllables at 10 months. Her language developmental age is 10 months and developmental quotient is 83%. In social and adaptive milestones, she attained social smile at 2 months, recognizes mother by 4 months, stranger anxiety by 7 months, and she started waving bye-bye by 12 months. Her social developmental age is 9 months, developmental quotient is 75%, and vision and hearing was normal for age. So impression is isolated motor delay, sir. And ma'am.
Definitely there is a motor delay, but
yes,
other milestones also not up to the mark. So
yes,
you are
sir.
thinking
She's
it is because
catching
of
up.
nutritional problem, or there could be delay in other areas also. Because nutrition also, she is
Yes,
not
sir.
up to the mark.
Yes, sir.
So do you think it is because of that, or it is because of the disease?
Because of the disease,
Maybe she
then
requires
nutrition, sir.
Intercurrent illness.
Yes,
which is
ma'am.
delay in other domains too, but predominantly it is delay.
Motor, yes, ma'am.
Okay, continue.
Yes. In the IT history, according to 24-hour recall method, before the onset of illness, her actual calorie intake is 600 kilocalorie per day against the expected 1000 kilocal per day with a deficiency of 400 kilocalorie per day. And she is taking protein 10 grams per day against expected 20 gram per day with a deficiency of 10 gram per day. Predominantly, she was exclusively breastfed till 6 months. She took around 8 to 10 feeds per day. Currently, she is on tube feeds with the complementary feeding. They are giving every third hourly feeds now, sir. Immunization history.
She is getting much below calories and protein,
Yes,
what is then required. So I think when she was going for checkup, they should have picked her up and try to give nutritional advice. Although she was giving breastfeeding, this child had difficulty in sucking, you said.
Yes, sir.
So palliative feeding was given.
Yes,
Whether
sir.
it was sufficient or not, that's also important.
Yes, sir.
Overall, there is a poor nutritional intake from the beginning.
Yes, sir. She was not able to suck and swallow semi-solids also. So, in immunization history, she was immunized according to Indian Academy of Pediatric schedule. Last vaccination given at 9 months of age. In socioeconomic history, according to modified Kuppaswamy scale, they belong to lower middle class, class 3, based on education, occupation, and income of the family. Family history, a baby is a third born to non-consanguineous parents. There was no history of any neuromuscular disorder or epilepsy in the family. History of spontaneous abortion after first pregnancy at 3 months of gestation. No further details were available for the abortion history, sir.
She's second born child. The second was an abortion.
Second one is abortion, ma'am. Third, she's a third born, ma'am. First alive child is 6 years old and alive and healthy, ma'am.
Continue.
Yes. Summary, this is a 12-month-old female infant, third born to non-consanguineous parents with antenatal oligohydramnios, smooth perinatal transition, floppiness of all 4 limbs since 2 months of age, more of symmetrical, proximal more than distal involvement with motor delay, feeding difficulties requiring tube feeds, recurrent infections in the form of respiratory and urinary tract infection, now currently admitted with urinary tract infection. I would like to consider the possible differentials, spinal muscular atrophy and congenital myasthenic syndromes, congenital myopathies, Pompey's disease, and syndromic causes, Prader-Willi and neurometabolic causes.
Okay, you have to say first it is like an central related cerebral cause, or it is like an lower motor neuron cause. So how do you differentiate?
In central cause, the child will have seizures, ma'am, and global developmental delay, and the child will have perinatal insult history.
Not necessarily, because what are the cerebral causes for hypotonia, which presents with a floppy infant?
Cerebral palsy, ma'am, hypoxic ischemic encephalopathy sequel, syndromic causes like Down syndrome, hypothyroidism can present with central hypotonia, and metabolic causes like Pompey's, paroxysmal disorders like Zellweger's, cerebral malformations can present, ma'am.
Okay, Pompey's can have predominantly element involvement. So cerebral causes, as you said, like you need to consider chromosomal disorders, Prader-Willi syndrome, malformations of cortical development, and among the metabolic causes, you can consider paroxysmal disorders and mitochondrial disorders.
Yes.
And so what the central cause, like they predominantly have a global developmental delay, and in the peripheral cause, it's predominantly the isolated motor delay.
Yes.
Some of the peripheral causes can also have like a global delay, like syndromic congenital muscular dystrophy, but as a rule, like they predominantly present with the motor delay. So other than that, what else in the history you can have? Except for the developmental delay.
Yes,
so
seizure history.
So the coexisting other neurological signs and symptoms would be more common with the central cause. Other sites of cerebral, other sites of cerebral dysfunction like seizures and other behavioral symptoms might be more common with the central causes.
Yes,
so other than that, in the with regard to wasting, because this child has a nutritional component also, but wasting is more pronounced in which cause, like if in the cerebral cause or in the peripheral?
More of peripheral cause than central cause.
Yeah. So the weakness will be more pronounced, disproportionate to your wasting in a central cause, but the wasting would be more pronounced to the peripheral cause.
The peripheral cause. Yes.
So with regard, so this based on your history, this is a child who's otherwise having no perinatal risk factors except for like antenatal, and she had smooth perinatal transition. We can't say because she had feeding difficulty from the day one of life, right? Like she had sucking issues from day one of life. So that's evident birth asphyxia, but there was a feeding issues starting from the day one of life, and there was floppiness of limbs which was noted from early infancy. How do you differentiate? How do you say there is a proximal more than distal gradient based on your history?
And the child is not able to get up from the supine position to sitting position, ma'am.
What does that
indicate? Axial muscle weakness, more of proximal.
No, axial doesn't mean proximal. Proximal distal gradient is for the appendicular muscles. So the axial weakness is the child has a difficulty in rising from supine position to sitting position, which means that there is an axial neck flexor weakness.
Neck flexor weakness.
Yeah. So with regard to the appendicular muscles, the limb involvement, how do you say there is a gradient, proximal more than distal? How do you differentiate from the history?
If the child is older child, we can ask for how she is holding slippers. Is he falling from the for distal a distal weakness, ma'am, and how she's climbing stairs.
So, no, for this particular child, like not for the older child, for this child, you said like distally she was able to grasp the objects well.
Yes, ma'am. Yes, ma'am. Grasp.
So, but she was having difficulty in lifting the arms, upper limbs above the head, right?
She's able to lift the arms above the head, ma'am.
Then based on the history, it will be difficult to say it's proximal more than distal because she's able, she's having preserved both like a proximal muscle as well as the distal muscle function. So it would be difficult to say. So it is floppiness alone without any weakness, you mean to say, because she's able to perform all the activities normally, like reaching for objects, grasping objects, taking,
transferring objects,
taking objects to mouth and lifting arms overhead.
Yes, ma'am.
So is there a paucity of spontaneous movement reported by the mother? So when the child is on the bed, like did the mother observe there is a paucity of movements when compared to because this is a second live child. So previously there's another child for comparison. So
yes, ma'am.
Activity?
She didn't, she couldn't tell evidently that there is reduced spontaneous movements, ma'am.
Okay.
But
so,
comparatively, it is mildly there like that. She was able to pass.
Is there a gradient between the lower and the upper limbs? So I would say like there is historically there is a difficult it's difficult to differentiate between the gradient proximal and distal, but there is axial weakness and there is appendicular weakness too. But in the appendicular weakness you have to qualify in terms of the functional disabilities what the child has. So the upper limb function, you say, according to mother, it's relatively preserved. With regard to the lower limb, like what would you say? Like by this time, the child should have started walking with support.
Yes,
so there is
the
a
child
definite.
is not it started.
So there is a gradient of involvement between upper and lower limbs. Lower limbs, you would say, like it's more involved than the upper limb.
Upper limb, yes.
But gradient-wise, proximal to distal, it would be difficult to say from the history, but maybe in the examination you can qualify it further. So
Yes,
and also, is there a bulbar weakness? You said there is an axial weakness, there is an appendicular weakness. Is there
not able to swallow?
Yes, ma'am. She's not able to.
Okay, so is there any pooling of secretion or excessive salivation?
No, ma'am. No pooling of saliva. No pooling.
So only difficulty was
not
there.
able to swallow.
She cannot swallow semi-solid. You said like when
compared to liquids, semi-solid is very difficult for her to swallow.
Okay, and with so this is based on your history. It points more towards the element weakness. So lower motor neuron weakness, where exactly in the motor unit? So is it an anterior hornsel disease, or it is a nerve, or it is a neuromuscular junction, or it is a muscle? So how will you differentiate from the history?
When the anterior hornsel is involved, the child's sensorium will be normal, ma'am. Isolated motor delay will be there with floppiness.
The anterior hornsel disease, it'll be like you will have proximal more than distal weakness.
Distal weakness, yes.
It will be predominantly isolated motor weakness or motor delay. Yes. And then you will have wasting disproportionate to the weakness.
Yes, ma'am.
The anterior hornsel disease. And there will not be any sensory involvement, and there will not be any diurnal fluctuation in the weakness, and there will not be any fatigability.
Yes,
so these are things which favors the anterior hornsel involvement. What does your child have?
No diurnal variation, no fatigability also, ma'am. And
so is there any wasting? Did the mother observe any report any wasting of the muscles?
No, ma'am. No visible waste.
Okay. So you could still consider anterior hornsel as one of the possibilities based on your history.
Yes,
less likely to be a nerve. Why is it less likely?
Sensation is preserved, ma'am, and
so the distal
will be more than proximal.
And also they usually have you can have isolated motor neuropathy, but if it is like an early onset like HMSN, usually they have some sensory findings as well. So this child doesn't have any sensory loss, so no evidence of any HMSN features or no evidence of HSAN features, hereditary sensory autonomic neuropathy. There are no autonomic symptoms too. And also there are no trophic ulcer, no spontaneous fractures too.
Yes, ma'am.
So a nerve seems to be less likely. So is it like a neuromuscular junction? Congenital myasthenic syndromes?
Possibilities there.
Yeah, you can it can still be possible without a clear diurnal variation and fatigability, because those symptoms might be well observed when the child grows up later when engaged in more motor activities. So you could still consider neuromuscular junction as one of the possibilities from the history. And how about a muscle disease?
Muscle disease is also possible.
Okay, so among the muscle disease, what are the features that are favoring, like from the history? Isolated motor delay.
Yes, ma'am. Isolated motor delay.
So that is both axial appendicular weakness.
Yes, ma'am.
And
Feeding
there is a
difficulties.
bulbar weakness as well. How about respiratory muscle involvement? Did the child have any evidence of any like abnormal shaped chest or any restricted chest movements or any weak cough?
No, ma'am.
Okay, so muscle can still be a possibility. So based on the history, we can say that sites of anatomical sites of localization could be either an anterior
Anterior neuromuscular junction, muscle,
or it could be a muscle. So among muscle, you have different etiological possibilities. One is like a congenital myopathy, where it is just present with an isolated motor delay, or it could be like a congenital myasthenic syndromes. It could be a presynaptic, synaptic, or postsynaptic cause. And then you have the other possibility is the congenital muscular dystrophy.
Muscular dystrophies, yes, ma'am.
Non-syndromic type or a syndromic type. Syndromic type usually has a global delay to start with, and they have more systemic involvement. So if at all, in this particular child, non-syndromic congenital muscular dystrophy would be a possibility.
Among all these, what do you think is the most likely?
I feel from this point, it's very difficult to say, sir, but with the examination,
I am asking
I would like to comment more after the examination. From the history, if I'm supposed to make a comment, I would place anterior horn cell disease and a muscle disease as two possibilities top on the list.
Yeah, so probably we need to look more in the terms of some lower motor neuron type of paralysis involvement. Spinal muscular atrophy would be one of them. And of course, other things we have already discussed. And there is some bulbar involvement also, because he's not able to swallow, not able to suck. This indicates that some involvement in the sucking and swallowing also. So probably we should think more in terms of a lower motor neuron type of involvement. Okay, you can continue with the examination.
SPS sir, your questions and comments, please, sir.
Yeah,
Bala,
two
sir?
or three things. Dr. Kritika.
Yes, sir.
I would strongly disagree with you that you're saying the whole thing started at 2 months of age. That's not, that doesn't look likely. For the simple reason, Madam said, even in the newborn period, this baby had feeding difficulty.
Yes.
Indicating that there is some oromuscular weakness right in the newborn period. One. And she's a multigravida.
Yes.
And you could have even asked her questions whether the antenatal movements of the fetus were less when compared to the previous pregnancy. That would have given you a definite clue the whole thing had started right in utero.
Yeah, she commented on that, sir. She told like the quickening was also normal and the fetal movements were normal compared to the previous pregnancy.
Yeah, that's one. But she said the whole thing started at 2 months. That's not compatible with that. Floppiness.
In the beginning itself, there was some problem.
There was a
She was not
problem.
able to suck.
Baby did not take feeds at all, did not suck well, and the mother would definitely give the history that when compared to the previous baby, this baby was not sucking well.
Yes,
Indicate that some weakness around the oromuscular region. That's one. Second, two other points could have given a clue that this lesion is in the anterior horn cells. Intelligent mothers would give you also a history of fasciculations. You can definitely get a history. And if fasciculations are going to be there, it is going to localize the lesion to anterior horn cells. Though rarely, you can get fasciculations in, several other disorders other than SMA. I'm not going to go into that, including, syringes, etc. So that is one history you could have got. Any fasciculation would have given a clue that the whole thing is definitely anterior horn cell. Right? That is two. And the third thing is, this mother, an intelligent mother, would also give you history. So the baby, other than weakness, the baby has been completely neurologically normal. That would have given you a clue that the problem is likely to be anterior horn cell. Completely active baby, very nice smile, everything fine with central functions. If that is there, you can swear on an anterior horn cell disease. That's the next point. Last but not the least, intelligent mother would also tell you that there is paradoxical breathing.
Yes,
That
sir.
history also can be obtained if the mother is intelligent. If you ask a leading question, and that paradoxical breathing, which is there in an infant with spinal muscular atrophy, because the diaphragm is preserved until late, is extremely characteristic. Extremely characteristic. Even with the history, you can pinpoint the diagnosis to anterior horn cell. This looks like an anterior horn cell, though you can have sometimes a combination of both central and anterior horn cell. That's one other possibility. Second is still a muscle disease is not ruled out. Neuropathy is extremely unlikely, and neuromuscular junction with this history of non-variability is very, very unlikely. So with this history, you should put your money on anterior horn cell first. Second, probably on a muscle. Third, if you are very sure that there had been some cognitive delay, also a combination of central and peripheral. These are my thoughts at this point of time.
Thank you, sir. Thank you, sir. Balashankar, sir, do you have any comments?
No, ma, please carry on.
Okay, sir. Okay, sir. Kritika, please proceed, ma.
Yes. In general examination, the child is alert, awake, looking around, interested in the surroundings, no high-pitched or weak cry, and the baby lying in supine position on the bed with both legs abducted and lateral surface of the thigh and lateral border of the feet touching the surface, with hands lying on the side of the head with elbows flexed. Her vitals temperature was 98.6 Fahrenheit on the time of examination. Heart rate 130 per minute, regular in rhythm, normal character, and pulse volume. Felt equally in all peripheries. Respiratory rate was 36 per minute. Abdominothoracic breathing, no retractions, no paradoxical respiration. And her blood pressure was 90/74, recorded in right upper limb, and her saturation was 98% in rumor. Coming to anthropometry, her weight is 6.9 kgs, which is -2 to -3 standard deviation, less than third centile, and the inference is moderately underweight. And her length is 72 centimeter, which is within -1 to -2 standard deviation, and centile wise 15 centile, which is normal. Head circumference is 43 centimeter, coming in third to 15 centile. Her weight for length is -2 to -3 standard deviation, moderate wasting, and mid-arm circumference is 13.5 centimeter, which is normal, and the inference is failure to thrive.
Do you think all these measurements are related to malnutrition only?
No, sir. With the nutrition and because of the difficulty in swallowing also, sir.
So basically it is a malnutrition, because you see all parameters are less uniformly
Yes,
below the norm.
weight is more affected than length and head circumference. These is the growth chart, head circumference, and weight. It's the length chart, sir.
So what is your impression looking at the height, head circumference, and weight?
Her weight is less than third centile, sir. Which indicates she is failing to thrive, sir.
So
And she has
malnutrition
not
part
crossed.
is likely to be more, because compared to the height and head circumference, which are little bit.
Circumference. Yes.
Continue.
In head-to-toe examination, head appears normal in shape, anterior fontanelle is open, admits tip of the finger, no overriding of sutures, sparse hair was noted, and in faces, there was depressed nasal bridge, protruding ears, no myopathic faces. In eyes, no squint, no cataract, no ptosis. In oral cavity, tongue was normal, no fasciculations, no high arched or cleft palate. No chest wall deformities noted. There was a bilateral dorsum edema in the feet, non-pitting with overlapping toes. No neurocutaneous markers. Genitalia was normal, spine also normal. This is the image of the child. She has dorsal edema in the bilateral feet, sir, with the overlapping toes also. A depressed nasal bridge with protruding ears also there, sir.
And did she have any pectus excavatum or any scoliosis?
No, ma'am. No pectus excavatum.
Was there any velvety soles and feet?
No, ma'am.
Was there any joint hyperlaxity?
No, ma'am. No hyperlaxity.
To be a Achilles contracture, if I'm not wrong. The right foot is plantar flex much more than the left, and it looks like there is an Achilles contracture. I don't know, Dr. Kritika?
Yes, sir.
Agree. Yeah. And in fact, sometimes, if you carefully observe the back of the feet of these young infants, you find more grooves. It may indicate plantar flexion or a contracture or even spasticity. It's always very, very useful to look at the back of the feet to identify whether there are any contractures. I'm sure there are contractures in the right foot, if not in the left also.
Okay, sir. Okay, sir. Systemic examination. In central nervous system, child was alert, aware, interested in surroundings, and interacting well with the parents. In cranial nerve examination, olfactory nerve could not be tested, sir. In cranial nerve 2, eye contact, fixing and following objects was present, and the pupillary reflexes normal. Fundus examination was also normal. In cranial nerve 3, 4, 6, extraocular movements were normal. In 7th nerve, no facial symmetry, no drooling of saliva. 9th nerve, no regurgitation of feeds. 10th nerve, gag reflex present. 12th, tongue was normal, no fasciculations. In motor system.
So basically, you think the difficulty in swallowing and sucking is related to muscle weakness?
Yes, ma'am.
Or nerve involvement?
Was the eye closure normal?
Yes, ma'am. Eye closure was normal.
And palatal movements were also okay?
Yes, ma'am.
Fundus normal.
Gag was present, ma'am. No asymmetry.
Maybe some minimal weakness might have been there. Because otherwise, why is not able to swallow? Because limb movement is okay. Okay.
Motor system examination, bulk, size of the both upper and lower limb appear symmetrical. No hypertrophy seen. Muscles are flabby on both upper and lower limbs. In tone, 180-degree flip test done. On pulling up the child to sit, there was subtle head lag in initiation, but then she was managed to have head control, and her head was in midline. While made to sit, rounding of back was noted, and head is in midline. In vertical suspension, slipping through the hands noted, no scissoring is seen. In dorsal suspension, a child was able to lift the head momentarily. Legs were completely extended. I have the images of doing vertical suspension and dorsal.
Did you observe slipping through the under the shoulder?
Yes.
Like the mother was telling, no? Mother also told you she was slipping.
Yes, sir. Yes, sir. Whenever she was trying to slip.
So what does that indicate?
It indicates flexor muscle weakness, sir.
So the shoulder muscles are weak.
Weakness is.
So it appears to be a generalized weakness rather than a localized weakness.
Yes.
Okay.
Coming to power, the best observed power in both the right upper limb and left upper limb is 3/5. And in both the right lower limb and left lower limb is 3/5. Anti-gravity movements were present. Palm or grasp was also present, sir.
So what is mean by 3/5?
The child was able to move the limbs against gravity, but not against resistance.
Fine.
Reflexes. In bilateral biceps and triceps, there was 1+ reflex, and in bilateral knee jerk and ankle jerk also 1+ elicitable, sir. And bilateral plantar response was flexion response. Jaw jerk is not elicitable. Primitive reflexes are all absent.
So these deep muscle reflexes are present, you mean?
Present, sir. Present.
So what does that indicate?
The reflexes are diminished, right? They are not 2+. They are just
Yes, sir.
elicitive.
Yes, ma'am.
Hyporeflexic. Not areflexic. So what is the
reflex?
So what are you ruling out?
Anterior horn cell we can rule out.
So there is no tongue wasting, no fasciculations.
No fasciculations. Yes, ma'am.
Again, history you have not in the examination also you have not identified any gradient between proximal and distal. There is both appendicular and axial.
Axial.
Yes. And also there is hyporeflexia. Okay. Spine and cranium normal.
Yes, ma'am.
So did you look for grip? Did you look for a grip myotonia, percussion myotonia?
In the baby, no.
So what additional signs other than this routine neurological examination in a child with a suspected element weakness? What additional maneuvers you have to do of any age? Leave of an infant, like any child with an element weakness, promoter unit weakness, anywhere from anterior horn cell or nerve or a neuromuscular junction or the muscle. What additional maneuvers or signs you specifically look for?
And we have to lift the child, and we have to give a stimulus in the lower limb, and if the child is flexing above the hip, it is more of central than peripheral. Stertor sign we should.
I'm asking for element weakness. What are the additional things for anterior horn cell? So additionally, you look for tongue wasting and fasciculations.
Yes.
And also, what else you look for it for anterior horn cell disease? In an older child, you will look for some other sign. Have you heard of polymony myoclonus?
Yes, ma'am.
So you have to in this particular baby, because it's an infant, it's difficult to ask the child to stretch the arm forward and look for it. But for an older child, you can always ask the child to look for lift the arms and hold it in the front position, and then you look for the low amplitude jerks occurring in the fingers. So that's polymony myoclonus. Again, is a diagnostic. A diagnostic for anterior horn cell pathology, right?
Yes,
so particularly for the muscle disease, for a neuromuscular junction, what else you look at? Neuromuscular junction, you can look for the fatigability. So you have to test for the fatigability. So you can do the forward arm abduction time. Forward arm abduction time. You can see how many minutes the child is able to hold for that position, and you can ask the child to repeatedly do flexion extension or abduction adduction movements, and then you can recheck the power. So you can see from the left at rest what was the power, and after exertion what was the power. So you can look for the test for fatigability for neuromuscular junction defects.
Yes,
for the muscle disease, like what additional things you'll check? You'll check for the gait for an older kid, and you'll check toe walking, heel walking, to differentiate between the weakness, the gradient of weakness, and you'll check for the Gower sign.
Yes,
and also you'll check for what else you'll check for?
Grip myotonia. Grip percussion.
For the percussion myotonia and grip myotonia. Yes. So, and also you'll check for what else you'll check for in the muscle disease? So other generalized markers you have to check for. What you have to look for the myopathic faces where selective
Faces, yes.
and selective wasting. Sometimes you might have pseudo hypertrophy of calf muscles. You might have hypertrophy of other muscles, biceps, triceps. So there may be selective wasting and selective hypertrophy. So you have to look for the pattern of wasting and hypertrophy. So these are the clues for the muscle disease. So for the nerve disease, you have to look for any trophic ulcers or any sensory deficits, and you have to also look for any nerve thickenings. These are the things you specifically have to look for in the child presenting with an element weakness.
Element weakness, yes. Other system examination, respiratory system, a work of breathing was normal, bilateral normal vesicular breath sounds heard. In cardiovascular system, normal heart sounds heard, no murmur. In abdomen are soft, no organomegaly, no scars, no sinuses. Umbilicus in midline, normal, hernial orifices were free. In musculoskeletal system, no contractures or deformities. Genitalia was normal, and in examination of mother, no myotonia, no ptosis, no myopathic faces.
But you told on the right side there is some contracture, isn't it?
That was not.
There was no contracture.
Yes, sir. Not sure, sir.
Maybe your picture was showing like that.
Yeah, on inspection, it appeared to be having a right plantar flexion, but on examination, you didn't observe any contractions. Is that right?
Yes, ma'am. There were no contractures.
No contractions.
Did you look for hip dislocation? Was there any evidence of bilateral hip subluxation or dislocation?
No, ma'am. No dislocation.
Okay, and spine was normal, no scoliosis.
Yes, ma'am. No scoliosis.
Okay.
As Madam was telling, the general examination, certain things you have not mentioned, although it may not be relevant to this child, like anemia, jaundice, edema, all those things also should be mentioned because
yes, sir.
This is a long case.
Yes, sir.
And when these movements are less, not only contractures, any trophic changes like ulcers and other things also you may have to see.
Yes, sir.
So those things have to be mentioned. Sometimes they may have a finding which may not be directly related to your case. Even they should be observed and mentioned in your findings when you say
Yes, sir.
general examination.
Yes, sir.
Okay.
Summary. A 12-month-old female infant, third born to non-consanguineous parents with antenatal oligohydramnios, smooth perinatal, with the history of generalized proximal predominant axial symmetric floppiness, noticed since 2 months of age with good spontaneous movements, associated with feeding difficulties and recurrent infections with failure to thrive, motor delay. On examination, the baby had facial dysmorphism, prominent ears, depressed nasal bridge, dorsal edema, overlapping toes, failure to thrive, normal sensorium, hypotonia with symmetric proximal predominant weakness, preserved reflexes with normal cardiovascular and respiratory system examination.
So
Okay,
here again, like again, you can just go back. Yeah. So again, it's difficult to say. Like I agree with your findings of dysmorphism, failure to thrive.
Yes,
hypotonia axial as well as appendicular hypotonia is definitely there, and the power is relatively preserved. The anti-gravity movements is still preserved, right? And also hyporeflexic. And there are no human signs like no the plantar responses of flexor.
Flexor.
Yeah. And I would say like there is again in the examination you have not identified a proximal predominant weakness, because you said that the power is 3/5 throughout.
Yes, ma'am. Throughout, ma'am. Yes.
So again, based on the
Generalized,
examination, yeah, it is involving both proximal and distal group. I agree with the symmetricity, and hypotonia with hyporeflexia is identified with the dysmorphic state. So this edema, what is the cause? Is it like you said it's a non-pitting edema?
Yes, ma'am.
So you think it is like a part of the dysmorphology itself rather than related to the
dysmorphism.
Okay. Again, at this point, like what would be your localization and what would be your etiological possibility?
Syndromic causes we can consider as the differential at this point now.
No, you have to say whether it's central or peripheral. Again, in peripheral element, motor unit, which is based on combining your history and examination findings. Are you thinking of anterior horn cell, or it is a muscle, nerve, or a neuromuscular junction, or it is combined up central or peripheral cause?
It is
Why do you
both
say
the so the baby had child had facial dysmorphism also with the element signs and symptoms, ma'am.
so? So the dysmorphic state, you can never have it in an element syndrome.
We can have myopathic faces and all.
You can have myopathic faces. Even you can have muscular dystrophies, syndromic muscular dystrophy, element predominant. So it's difficult to say like a human finding from the summary of what you have given. So I would still place it on an
element.
So which you will now suggest, like anterior horn cell, or a nerve, neuromuscular junction, or a muscle?
Muscular junction, muscle, and muscle.
Yeah, I would say more in terms of muscle, because of delay predominantly in motor milestones and having a axial involvement as well as appendicular weakness. Bulbar, you said like there is a significant feeding difficulty. Very surprising that the palatal movements are completely normal and the reflexes are normal without any pooling of secretion. So it is not going on with your history. And also so the child has like a proximal as well as a distal weakness with hypotonia with hyporeflexia. So I would localize at this point more towards a muscle etiology rather than an anterior horn cell or a nerve or a neuromuscular junction. So among the muscle, which would you say, like whether it is congenital myopathy, or congenital muscular dystrophy, or metabolic myopathy, or what else? Channelopathy. Channelopathy less likely because there is no fluctuation of symptoms, and they usually don't have like a predominant fixed weakness. They are episodic nature, or like the fixed weakness would not be so prominent. Fixed muscle shouldn't be so prominent. So your sodium chloride and calcium channelopathy seems to be less likely. So could it be a metabolic myopathy?
Yes, ma'am.
Yeah, metabolic myopathy, sometimes they can have certain dysmorphic states, like a few of the disorders can have overlapping findings. So what muscle disease, metabolic myopathy you think of? So congenital myopathy would be one possibility. Syndromic congenital dystrophy would be the second possibility. And third possibility could be a metabolic myopathy. What are the possibilities?
Pompey's congenital
Pompey's usually doesn't have so much of a dysmorphic state. They can have overlapping findings. Zellweger is a proximal, predominantly is a central cause. They don't have so much of predominant element findings. They have more of human than element findings. So that if this is the case with hypotonia,
glycosylation, congenital disorder of glycosylation.
It's a huge group, so you can still consider. What else?
Yes.
So what are the sources of energy? So metabolic myopathy for the muscle, what are the major sources of energy? It's a high energy demand organ, right? So it derives energy from glycolysis, glycogenolysis. It derives energy from Krebs cycle, from beta oxidation. So it derives energy from oxidative phosphorylation and also phosphocreatine pathways and purine nucleic acid. So muscle is a high energy demand organ. So it derives energy from multiple pathways. So all genetic defects in any of this can present with early onset symptoms depending upon the residual enzyme activity. If it is like a nonsense mutation where the enzyme activity is very less, they can have like early onset presentation. If they have like a residual enzyme activity, they can have a late onset presentations. So here, like the point against metabolic myopathy is there is no episodic fluctuation with the intercurrent illness. So like whatever weakness is there. Like even during intercurrent illness, there is no weakness. And never had any evidence of any rhabdomyolysis or myoglobinuria. So which makes like metabolic myopathy lower down the list. So I feel at this point like muscle localization seems to be possible, and among which like you can consider congenital myopathy and syndromic congenital muscular dystrophy to be on the top of the etiological possibilities.
Yes, ma'am.
These metabolic diseases, they improve with age because this child has attained some milestones. Gradually, it is improving.
Yeah, some of the metabolic disorders like your fatty acid oxidation, so they do gain the milestones. They have a delay, motor delay would be there. They gain milestones, but they have worsening with intercurrent illness, which is not typically there. So other glycogen storage disorders usually they have early onset symptoms, and they can have like a static disease, or they can have worsening with intercurrent illness. Some of them slowly gain milestones too. So the gaining of milestones doesn't totally exclude the metabolic myopathy, but congenital myopathy and muscular dystrophy seems to be higher in this particular child.
Yes, ma'am.
So how will you evaluate? How will you plan the workup in this child?
First, we have to divide either central or peripheral, ma'am. If we are considering now we are considering peripheral, ma'am. So syndromic, non-syndromic in that approach, first we have to do creatine kinase, electrolytes, and liver function test, ma'am. And if it along with lactate, pyruvate, torolate, mitochondrial also, ma'am. If the creatine kinase is elevated, along with these, we should send electromyography, nerve conduction studies and all, ma'am.
So what do you expect the serum creatine kinase in this child?
Normal or
What
mildly
happens in
elevated.
congenital myopathy? What happens in congenital muscular dystrophy to the CK level?
Myopathies will have normal or mildly elevated levels, ma'am.
Yeah, congenital myopathy usually have normal levels. Rarely they have mild elevation. Congenital muscular dystrophy can have mild to moderate elevation of serum creatine kinase. So why do you do electrolytes in this child?
Channelopathies.
So based on your history and examination, it's highly unlikely that it's like any of the channelopathies. So it doesn't fit in with the hypokalemic or hyperkalemic periodic paralysis. The symptoms are not like that. It is like a chronic static weakness.
Yes,
so but the child is having undernutrition. So would you work up the other causes which can lead on to worsening of weakness, like vitamin D deficiency or vitamin
thyroid profile,
profile treatable cause, and
B12
also,
levels.
and also albumin. Though I understand it's a non-pitting edema, so your liver function test. So what else you'll work up?
Along with that, electromyography, nerve conduction study. We can
Nerve conduction in this child, what will you find? What findings will be there?
Repetitive nerve stimulation. Just
so if you do an RNS, that is for looking for the congenital but you do, but here we are not considering that higher in the list. But still, if you're planning for a nerve conduction, it should be a complete nerve conduction with repetitive nerve stimulation and an EMG. So you can in the EMG you can look for the myopathic potentials, and in the repetitive nerve stimulation RNS at 3 Hz, you will look for the electrodecremental response. Okay. So what other investigations will you plan in this child? So one is blood biochemistry and the serum CK levels.
Serum CK levels, thyroid profile, B12 levels, albumin.
Yeah. And then what else?
Along with
other investigations in this child for confirming the diagnosis.
Electromyography, genetic testing.
Did the child had a newborn screening when she was born? Did she have any TMS done?
No, ma'am. The child was delivered in primary health center, ma'am.
Okay. So it is good to do a basic
thyroid profile was done, ma'am.
It's good to do a basic metabolic profile. Like you can send the blood lactate ammonia and the TMS for this child, because any of the fatty acid oxidation defects would be picked up on the TMS and also the urine GCMS. So basic metabolic profile would be needed. And for confirming the diagnosis, what investigations will you plan?
whole exome sequencing with the MLPA.
A whole exome sequencing with MLPA. Why do you want to do an MLPA? If you're considering an anterior horn cell disease SMA, then you should go.
Whole exomes.
Then you should go in for MLPA, looking for SMN gene, exon 7 or 8 deletion. But here your possibilities are congenital
myopathies, muscular
dystrophies. So some of the congenital muscular dystrophy, as I said, syndromic ones can have like a cerebral malformations. They can have
neuroimaging.
So it is good to have like an ophthalmological evaluation. And if CK is elevated, I would definitely consider congenital muscular dystrophy as one of the possibility because of the dysmorphic features, and I would consider an imaging also. But confirmation of the diagnosis, I would suggest to send for the whole exome sequencing.
Whole exome sequencing, yes, ma'am.
So have you got the findings on this child? Genetic reports are available?
No, awaited, ma'am. Genetic reports. We have sent whole exome, ma'am.
Okay, so imagine if the whole exome turns out to be negative, then what would you plan next?
Biopsy, muscle biopsy.
So most of the monogenic disorders, your nuclear and mitochondrial genes, and when you're considering the whole exome, including mitochondrial genome sequencing, would be picked up on that. Would you think that the muscle biopsy will give an additional finding or an additional diagnostic accuracy? So which set of disorders would be missed out in whole exome sequencing? When you don't include the copy number variants, your chromosomal disorders would be messed up in the you should consider a chromosomal microarray. So there are certain group of disorders, chromosomal disorders, which can be messed up with the chromosomal microarray too. What are they? Child has, yeah, exactly. So the child that also in chromosomal array you can have a clue for the Prader-Willi
deletion.
So if there is some balanced translocations or some numerical abnormalities trisomy, it is better to go ahead with the karyotyping.
Karyotyping, yes.
Yeah. So it depends upon your clinical index of suspicion. So
yes,
you need to develop the genetic testing accordingly. So
yes,
how will you manage this child till awaiting the genetic reports? So what are your priorities in management?
Feeding with the NG tube or gastrostomy tubing if aspiration is noted, ma'am. With physiotherapy for the for motor milestone development and on regular follow-up for developmental assessment, along with for weight gain, we have to give the dietary schedule for them to feed accordingly, ma'am. Along with that, to manage the recurrent respiratory and urinary tract infection, to prevent intercurrent weight loss and intercurrent illnesses.
Because dysmorphology is there, it is good to exclude other structural abnormalities, like you can do an ECG, echocardiogram, and also an ultrasound to look for any coexisting intra-abdominal pathologies.
Yes,
and also like the management aspect, like you should, as you said, like here nutrition you have to optimize the calorie and consider the or switch over to the G2 in the family's willing. And also you should consider the immunization. So what specific immunization in this child having a recurrent respiratory tract infection? So in addition to the routine immunization, what all should be suggested for the child?
I will make sure she'll get an annual flu vaccination, ma'am, under 2 PCV doses and 1 booster doses, ma'am. And along with
so your growth, nutrition, and immunization should be taken care of, and then you should start on the physical therapies, the muscle strengthening exercises, and also to prevent the contractures. So you should consider the physical therapies, and also you should keep on orthopedic surveillance to look for any hip dislocations or any contractures or scoliosis.
Yes.
So you said like there are no respiratory involvement as of now, like the pattern, there is no paradoxical breathing, and the pattern of respiration is completely normal.
Yes.
So you should also keep a monitoring for the progression of the weakness. She has bulbar weakness, and she also has bulbar symptoms, and then she has recurrent respiratory infection. You have to keep a tab on the progression of the respiratory muscle weakness also.
Yes.
So, and then once you have the genetic diagnosis, you can offer the specific treatment, like in addition to the supportive measures, you can consider the specific therapy. So most of the congenital myopathies, you have only supportive management for congenital muscular dystrophy as well. But if it's congenital myasthenic syndrome, you can consider like medications like pyridostigmine, ephedrine, or albuterol, depending upon the genetic defects, whether it's presynaptic, synaptic, or postsynaptic.
Yes.
So for the other group of disorders is the anterior horn cell. The anterior horn cell disease, SMA, if you're considering, then you should go for the MLPA rather than the whole exome sequencing. So because many of the cases will have, 98% of cases will have SMN gene deletion. So exon 7 or 8 deletion in the SMN1 gene. So you have to look at the SMN1 deletion, and also you have to calculate the SMN2 copies to consider the other form of support, like specific therapies, because nowadays you have Restiplam, you have nusinersen, and also so you have to plan on the specific therapies based on your final diagnosis.
Yes,
and also you have to consider offering the genetic counseling to the family, because the risk of inheritance, and also the planning for the next baby. If the family is planning for the next child, you have to offer the prenatal diagnostic testing availability too.
I think you are
Thank you so
doing
much.
a good job. Basically, I think the treatment is supportive, as Madam was telling, and physiotherapy and later occupational therapy, all this thing will go on. What is the difference between physiotherapy and occupational therapy?
In physiotherapy, to prevent contractures and to make them more in motor milestones, sir. In occupational therapy, they will more focus on fine movements, sir.
So to meet the daily needs.
Yes, to meet the daily needs.
So we'll keep the final diagnosis query now. So which one is more likely now? Because Madam has suggested it is more likely to be
The referral was congenital myopathy or
okay, maybe with the clinical examination we cannot definitely not confirm a diagnosis. We can only suggest diagnosis.
Yes,
and we have to investigate and find the final diagnosis. But till then, of course, the supportive care is important.
Yes.
Once you have a definite diagnosis, counseling, family counseling can be done. This mother maybe, how old is she?
26 years old, sir.
So if it's a young mother, then again,
Yes.
next pregnancy, how to handle that. Those things also will come into picture.
Yes, sir.
Dr. Balashankar wants to ask something.
Yes, sir. Sir, good evening. Thanks for giving me this opportunity. I got a few doubts. Madam Sangeeta may be able to answer. Madam, still you will consider a neuromuscular junction abnormality, madam, because we have been taught always ptosis is one of the cardinal features of myasthenic disorders. When it is not at all there, should we still consider neuromuscular junction abnormality, madam?
So if you see neuromuscular junction disorders, it is like congenital and acquired, sir. So congenital myasthenic syndromes, they have a list of genes causing presynaptic defect, synaptic defect, and postsynaptic defect. So the phenotype is not similar for all of them. So some of them have early onset ptosis and ophthalmoparesis. Some of them have later onset ptosis and ophthalmoparesis. So the pattern of symptoms and the distribution of weakness would vary depending upon the underlying genetic defects. So at 1 year of age, we may not be completely able to exclude based on the absence of ptosis or ophthalmoparesis, but we should still consider because it's one of the potentially treatable disorder.
Okay, madam. Thank you. Then should we consider still Pompey? She gave one DD as Pompey. At this age, I think they should have developed cardiomyopathy, and usually they die in early infancy itself. By 6 months or so, they die of cardiomyopathy. Should we consider POMP, which is predominantly muscle manifesting and without a cardiac? Is it there anything type? Because so many things have come, type 1, type 2 and all. I do not know whether POMP can have without cardiomyopathy only weakness of the muscles.
You
Then,
can
yes, madam.
Pompe's disease, again, it's one of the treatable disorders. So they present predominantly with a muscle weakness. Some of them rarely have human signs too, but predominantly it's an element weakness. So again, your whole exome sequencing will pick that up. So based on the clinical examination, they just present with symmetrical proximal muscle weakness and cardiac involvement. But you have a late onset Pompe's too, where they manifest in very late age groups, like young adults, where they present with the again, from this particular child who has findings of symmetrical proximal muscle weakness, we would still consider metabolic myopathy as one of the possibility, but presence of dysmorphic state and other findings favors more towards a congenital muscular dystrophy or a congenital myopathy.
Yes, madam. Regarding this dorsal foot edema and overlapping of fingers, my comment is as there is decreased movement, there can be mild edema there. So we need not give much importance to that edema per se, number one. It may appear edematous, number one. Number two, this overlapping of fingers, is it due to decreased movement of fingers, doctor? Because if the fingers, the toes, toes doesn't move also, they may occupy some different positions there. So I doubt to whether it is just overlapping of toes or no movement of toes at all. If it is so, then it comes to distal weakness, something like that. That's what I am little worried. Are you sure that the finger movements are very good, doctor?
Yes, sir. Movements are good.
Especially upper limb was normal, I think, because holding the
Yes, the
objects.
finger movements are absolutely normal, Abdina. Then what I'm telling may not be significant. But you have to keep in mind whether this just to overlapping of the fingers due to just not moving the toes at all. That's what I doubt. Apart in that, one more thing. Any investigation you have done? You have done any MRI or anything?
MRI we have done, sir. Normal, sir.
Normal. So
Normal,
no
sir.
CNS abnormality.
No, sir.
Okay, because there are dysmorphic features, it is better to do a MRI also to rule out any CNS abnormality. If it is normal, then it is okay. Then in the treatment, you so told gastrostomy, yeah?
Currently, she is on NG tube, sir.
எதுக்குமா இப்ப she is not able to swallow. Is it she's the weakness that bad, pharyngeal weakness? Still she is on tube feeds only? Or only have to come into the hospital, you put on tube?
Her weight
For
is
the
half the
past
normal.
2 months, she's on tube feeds, sir.
Oh, for the past 2 months she's on tube feeds.
She's on tube feeds. She's gaining weight after starting tube feeds.
The weight was, I think, 6 kilos or so.
Yes, sir.
For 2 months he is on tube feeds.
Yes.
Oh, okay. Then what madam told is a most likely possibility. Either congenital myopathy or muscular dystrophy. That's these are the possibilities we can narrow down. Because CNS causes also we almost ruled out. Very rarely your syndromes. Just syndromes causing hypotonia. That is the next possibility, close possibility, according to me. That's it. That's what I have to say. Thank you very much for the opportunity.
Thank you so much, sir. SB, sir, your comments and remarks, please, sir.
Yeah, 2 or 3 comments. One is that the presence of facial dysmorphism and unusual features like edema indicate that this is something beyond, a simple neuromuscular junction lesion or an anterior horn cell lesion. This might be a combo of central cum peripheral. That's one. Second, I don't think tube feeding is ever going to improve this baby. It will only increase the risk of GER, increase the risk of aspiration. Feeding gastrostomy only. I think in India, I'm sure our neurologists would agree, we are very defensive about feeding gastrostomies for improving nutritional status of CNS impaired children. We should be proactive. I don't think I'm sure with 2 months of tube feed, this baby has not gained weight. Yes or no, Kritika?
Around 1.5 kgs gained.
Pardon?
Increase is there.
1.5 kgs she has gained, sir.
Oh, that's fantastic. Unexpected. It will only increase the risk of aspiration. So long-term gastrostomy will help.
Yes,
And
sir.
of course, when you have not had any diagnosis with the exome sequencing, I think we have to look for chromosomal thing. As Madam said, we
Yes,
have
sir.
to
Yes,
investigate
sir.
further. And last but not the least, with these facilities being made available now, what we earlier thought that they are all only SMA, now we are getting fancy diagnosis because of exome sequencing. I'm sure Dr. Sangeeta would agree. In fact, I was bold in one case where there was classic fasciculation. It turned out to be, what is it? I'm not getting the name. It starts with M. What is Mirosina? What is that, madam?
Myrosin deficient and myrosin
Yeah,
positive.
yeah. It had classic fasciculation. And as a clinician, I swore on SMA, but the Medgenome gave a report it's Mirrosin affair. Of course, we didn't do MRI. I believe.
Even late onset Pompe's can have paraspinal fasciculations. It's also because of the anterior tonsil involvement. So
Yeah.
we can't just stamp a SMA based on fasciculations.
Yeah, yeah. So, I was swore on SMA because of the presence of fasciculations, and I was wrong. So that can go wrong. Even, fasciculations, other than SMA, there are very few conditions like poliomyelitis, syringomyelia, organophosphorus poisoning, poliomyelitis, etc., etc. They're all very rare. Fasciculations means it is a degenerating peripheral anterior horn cell. Doesn't occur in any other condition. That's what we thought. Now we are seeing other conditions. So that is what these modern techniques are telling us. This is a very interesting case. Unfortunately, most cases, when you have a floppy infant, if you have a doubt, you blame it on the center, you are likely to be right. In this case, if you blame the center, we are likely to be wrong. It looks peripheral only. Okay, majority of hypotonias are only central. Majority of hypotonias are only central. And majority of hypotonias are only cerebral palsy. Because cerebral palsy is a disease of changing tone. First few months it may be floppy, next few months it may be rigid, toward the end of 1 year it may become spastic. We see that happening, and that's it. Anyway, it is a very interesting case, but unfortunately with all our investigative armamentarium, we could not get a diagnosis. I'm sure Aisha will do something else more and give us the diagnosis. Excellent discussion by Dr. Sangeeta and Professor Vishnu Bhatt. Thank you.
Thank you
Next
so
time, I
much,
think we'll have a
sir.
diagnosis.
Thank you.
Anything else you want to add, or we
Sir,
move
Vishnu
to?
Bhatt, sir, your closing remarks regarding presentation of Kritika.
Yeah,
Yes, sir.
overall, I
Your
think
closing
she
remarks
has done
regarding
a
her
good job.
presentation, sir. She did fairly well.
So,
Yeah, it was a great
Ma'am,
presentation.
your remarks, ma'am?
It was a great presentation. I totally agree with SBS sir that with the advent of genomics era, we have a lot of SMA plus syndromes. So where they have like overlapping phenotypes. So it is very essential to have a good clinical examination and meticulous history taking. Despite all this, like we might not be able to arrive at a diagnosis. So the genomics era helps in diagnosis of many of these new disorders.
Yeah, the one additional point, in such cases, Dr. Kritika, you
Yes,
should
sir.
examine the parents and look for clues for myotonia. That's something
Yes,
we
sir.
can
I
score on.
She
have
mentioned, sir.
examined,
She
sir.
mentioned.
All such cases which don't fit into any diagnosis, one of the clues you can pick up for myotonic dystrophy or myotonia, congenital myotonia, is examination of the parents and looking for, of course, I have not made any fancy diagnosis so far, but at least it's mentioned in literature that you have to examine parents.
Yes,
I
sir.
still remember there was a beautiful New England Journal article where our Indian neurologist, Dr. Krishnapadam, he was there in the discussion where they discuss floppy infant, and they pick up the diagnosis by diagnosing history of myotonia and the family, and then they prove right. They prove right. It's a case records of the Massachusetts hospital, which came about 10 years back in the New England Journal. So you must take history of myotonia and the family and myotonic dystrophy clues on physical examination, the parents and relatives.
Yes, sir.
I'm sure Dr. Sangeeta might have seen cases.
Yeah, myotonic dystrophies, again, the trinucleotide repeat expansion, you would not be able to diagnose based on your whole genome sequencing. The whole genome sequencing includes the trinucleotide disorders as well. So if you're having a high suspicion for myotonic dystrophy, then you should go in for a specific diagnostic methodologies to diagnose trinucleotide expansion disorders. It would like for that particular disorder. But if you're suspecting a myotonia or a paramyotonia related to sodium channel, chloride channel, or potassium channel, or your Anderson-Tawil syndrome, then your whole exome would be sufficient enough to pick up in most of the cases.
The more facilities available, the more diagnosis.
The diagnostic odyssey will be more.
Thank you so much, Sarsan ma'am. Kritika, it was a very great presentation. It's a moment to congratulate your mentors, Dr. Janani ma'am and Dr. Aisha ma'am. Your comments, please, ma'am. She presented so well. Aisha ma'am, are you there? Janani ma'am?
Not only that, Kritika, to stand before such giants itself is a very big thing.
Yes,
She would have
ma'am.
already underwent a final examination now.
She handled it
felt
so
like
well,
being in the
ma'am. She
neurology
handled it so well.
examination. Yeah.
So whenever SBS sir called Kritika, I had a jerk whether he is calling me and asking me to answer question. I was so.
My God, I would have addressed you as Professor Kritika. Don't worry.
Ma'am, no, sir, no. I'm
Sir,
always
we are
your
still
student.
students for you.
We are always your students,
And
sir.
still we
It's
feel
amazing
jittery.
discussion, sir.
Yes,
Sir,
yes.
and still
Sangeeta
we
madam
feel
and Vishnu.
jittery, sir. SB sir, still we feel jittery if you call us.
Yes, that's
Yeah,
what.
if you call us, we still feel jittery, sir.
My God, I see. I'm very unhappy after so many decades. I'm notorious rather than popular.
No, sir. There's a respect we have for our teachers, sir. Even in the moderator, when you call in the conferences, I get jittery, sir, still.
No problem.
Sangeeta madam and Vishnu sir, amazing discussion. Amazing.
That was an excellent analysis of that case. It was an excellent dissection of the case, I should say. Thank you so much, ma'am. Thank you so much, ma'am.
Great start to the program, sir. Great
Having a
start to the
neurologist
program.
supported me because basically I'm looking after neurology mostly. I think you got confused with it.
So the initial start itself is very amazing, sir. Still at 10:40, about 40 people are there in the platform, and 42 people are there in the YouTube still waiting to hear the knowledge of all the stalwarts here, sir. So it was an excellent start to the program. We'll see to that from the next event onwards. It's sharp 8:30 to 10. We will have it so that things will be on track, sir.
People will
Thank
have
you
their
very much,
dinner on time.
sir.
People will have their dinner on time.
On time also, yes, sir. So Sangeeta, thank you very much because we will not be able to have her here. She's on a sabbatical leave. If not, she will finish her OPD and rounds only by 1 a.m. or 2 a.m.
Yeah.
I know that.
I can't
know
see
that
her in Vellore, actually. I don't see her there in Vellore.
Yeah, she's back from Canada after her metabolic training, metabolic neuro training, and she's fortunately in a sabbatical till 2 months for her research. So we were lucky enough to have her and vast knowledge, experience sharing, and the same subject which you did in 2005 with me when I was your ward mate. So the same thing is ringing in my ears after 20 years. So thank you very much for here. And thank you, Vishnu sir. Your experience has mentored many people and still continues to do so in this platform. And Kritika, thank you very much. You have like a ringmaster. You have done the job going behind. And thank you, Dr. Prasanna. So you have taken hold again from the CCB to the TNSC too. And many thanks to SBS sir. You will always be there as I called you 2 days before the first two programs. You have started in an excellent flying manner for me, sir. continue to do so for me for the whole year, sir. Thank you very much for being here. And the team from Child Trust, Janani Madam, Aisha, and Kritika. So Kritika, you batted very well, and you have you have not gone out till 10:45. So you will be the best student from Child Trust. Thank you very much.
Okay, sir.
Thank you all for this platform.
Yeah. Thank you all for joining in this platform. Thank you.
Thank you so much. Shall I
Thank
end
you.
this meeting, sir?
Yeah.
Yeah.
End the
Thank you.
meeting?
Good night,
Good
all.
night, everyone.
Good night.
Thank
Yeah.
you.
Good night. Good night, all of you.
Good night.
Yeah,
Good
thank you.
night.
Good night.
Thank
Good
you,
night.
everyone.
Good night.
Thank you.